Hi, everyone. Thank you so much for getting on. We're really excited to get started with getting you guys some information. So I'll tell you a little bit about myself. I'm a psychiatrist in North Carolina, and I've been a CAP provider for about 7 years and now work with training therapists to be CAP providers. And about 7 years ago, when I opened that practice, I started collaborating with my husband, who set up a ketamine clinic. And so he's going to get on in a little bit to talk about his experience with that from the prescriber end. So our interest in sort of generating more offerings for you guys is because we are such a rich network of resources. There's so many skill sets and so much knowledge in this community. And the idea is to start over time getting some of us who know things to help those of us who are looking for information in different ways. So we're really excited to start doing more of this kind of thing and hoping that to hear from other people who may want to be part of that or part of teaching and offering things as well. I'm here today really to talk from my perspective as someone who does CAP on a regular basis, is really in that clinical world and doing psychedelic-assisted psychotherapy kind of on the ground in an outpatient setting. And to sort of my journey with what that was like, what the hurdles are, and what I've seen with other CAP trainees coming through our training in those kind of ways too. So thank you again, and I'll pass it to whoever's next.
Thank you. My name is Meidad Goldman. My background is in emergency medicine and later got also addiction medicine, seeing especially the way that mental health is being provided in our current health model. Definitely something that made you want to do more. We started our clinic in 2017, and then my wife Signi and I started the program in 2019, the ketamine-assisted psychotherapy. I work about 3 days a week for the past 6 years at the ketamine clinic, 3 to 4 full days, mainly IV ketamine, and providing both ketamine as a pharmaceutical kind of drug, as well as ketamine-assisted psychotherapy, providing therapy for our patient during their infusion.
A large question, but I'm really curious about, I know it's still pretty fresh for a number of us in the ketamine practice, but how have you seen your practice shift over time? How has it matured based on the types of conditions, clients, the people involved in care? What have you seen as the evolution from when you began to where you are now? In 2 minutes, please. So we'll go in the same order, and you can pass the baton to the next individual, and we'll go ahead and start with Signi.
Okay, that is a big one. My personal journey was kind of interesting because I started doing CAP around 7 years ago when there really wasn't a template. Not that there's a great template now, so that might be something to talk to you guys about. We're coming into this kind of work where there are no elders, there's no gold standards, there's no practice guidelines. And so when I started, really what we were doing at the time is sort of reading everything we could find about anything related to psychedelic medicine, anything related to ketamine and dosing, using all the therapy skills we could think of, trying to be really conscientious, trying to be super medically safe, and then sort of creating it. So it definitely has evolved. I feel like, in the beginning, there was that sense of, there's much more of a community now. So for me, it's just been, there's more people doing, more people talking about it. And it's not such a thing that I'm sort of feeling like I'm creating and not sharing where to, discovering as I go. But in retrospect, I'm kind of grateful for that experience because I think, because I went into it not knowing 100% what to expect from that kind of work, I think I was really able to notice and learn a lot, from the clients. So some of the things that have changed for me is in the beginning, I really only did this work with clients I'd had in my practice a long time and already knew very well and really felt safe about and so on. And of course, as time has gone on and we've gotten a lot more polished and sort of like confident about assessment and safety and fit and things like that, we now can screen people pretty quickly into the program and know, move people through in a more streamlined way. They don't have to have been my client for a long time and so on. So another big thing that's changed is working with other therapists. So therapists that are coming through our clinic, and this is a model that I think is worth letting people know, is the partnering of therapists who have their own practice in the region. So they don't have to be employed by us. They're partnering. They have their own practice, but they can bring clients through our clinic to do the ketamine work under supervision and so on. And we have training that goes along with that. So that's another way that's changed a lot, is there's more people doing it now, even in my own clinic, and there's all these amazing therapists that are doing it really well. So it just feels much richer.
Meidad, would you like to go next?
Sure. When we started our ketamine clinic in 2017, it was mainly for my wife Signi's existing patient with mainly depression, but various other, and then joining in session with Signi when she was doing ketamine-assisted psychotherapy, and then mainly for 2 years, almost from 2017 to 19, sitting with patients that are coming in for treatment-resistant depression and learning how to hold the space. One of the reasons why, I expanded a little bit my knowledge from emergency medicine to addiction medicine, and why we did a CPTR course. And I think it was very validating, as Bob mentioned, that ketamine is a really good choice. I mean, the psychedelic state, the altered level of consciousness, is a medium in which therapy can be delivered very effectively, and ketamine is a really good choice for many, many reasons. I will echo that with ketamine, less is more. I think this is the first time that we entered what is being coined as experiential medicine. So far in medicine, we never had a medicine that gives you an experience. You take a pill or you take a drug and you hope for a pharmaceutical effect. And this is the first time that you actually take a medicine and you're hoping for a pharmaceutical effect, but you have this experiential portion. And that experiential portion is super important. And I see other clinics that are giving ketamine with, propofol or Versed or some other, and it's kind of like, I think that they're missing a huge component of the essence of the treatment that we're providing. So the experiential, not just the pharmaceutical, is key. Less is more, and I've learned a lot, not just from the CPTR, but from Sandy and all the therapists that I've been seeing for the past 6 years, 3 to 4 days a week, learning a lot how to hold the space and how to work with patient to provide them, this is it's not an infusion clinic. This is something completely different. And throughout my other practice, my concierge house call practice, doing it with end of life, for example, and starting to get involved with end of life cases, I think that ketamine has a lot to offer on so many rims. And it's just humbling. You just learn every day as you go with each patient. And it's a really humble and a big privilege to join to someone else's journey.
Which segues into, I'm hearing a lot around teamwork, partnership, collaborations, and brings up the next question around ideas around setting up a ketamine practice and varieties of options. So I'd be curious to hear from a few of the panelists on how did you come to the decision over time or when you're starting in the business model and the clinical operations, kind of shifting to the how do we make it work in the code and like in real life, in the sense of from all of our intentions. So I'd like to begin perhaps with Meidad. If you'd like to describe your model with Signi and Sandy, that'd be wonderful.
Thank you. So our clinic is, I would say, mainly 98%. I mean, we have variety, but we are IV based, where each patient are seeing, the first 5 years they've been seen by me with Signi or another therapist. And we really try to take the patient, from beginning to start, as Bob mentioned, is really sitting with the patient, preparing the patient. We do IV. We have obviously the capability to do IM. I just over time felt that the IV experience was much better and also works better with therapy based on the kinetics of the medicine. And working with various trained therapists that have their own practice and learning to collaborate and work together has been kind of shifting. If in the beginning we started with 95 to 5% in 2017 of more pharmaceutical, we kind of now gravitate for more ketamine-assisted psychotherapy, so combining the pharmaceutical and the therapy together.
To clarify and make sure that I understand correctly, you're working there as the provider, as the prescriber, and
Right. And then
there who are sitting there with the patients at the same time.
Mm-hmm.
So either the patient that are just coming for the pharmaceutical are sitting with me, or another doc in our clinic, Dr. Lentini, who is also, she has a background in psychiatry. And if they're coming for ketamine-assisted psychotherapy, they will have a therapist that was pre-assigned to them. And we many times combine also. So patients are now combining a little bit more of the pharmaceutical track and the ketamine-assisted psychotherapy track and combine them together. So they will have a therapist with them throughout their induction series or throughout the maintenance. And so the ratio of patient has gravitated a little bit more and more to combine the therapy with the infusion itself.
I was gonna just say that I've seen it done so many ways now that we've trained people and we've sort of seen where people are landing with their jobs. And that it seems like the three, ingredients that you need to do psychedelic-assisted psychotherapy right now, which has to be with ketamine right now for people who may be in our audience who are just wanting to start a job or a career, it's learning ketamine. So one, there's the training piece, but in order to work in this field, you need a prescriber administrator, you need a psychotherapist or someone with mental health therapy training, and then you need like the admin person who's running things. And obviously some of these can be the same people, and you need someone with IV skills. So those are the things. Now you can subtract the IV skills. For those of you who are listening, if you want to have a practice that doesn't use IV, then you can take that piece out. And if you want this, the smallest scale version of practice that I'm aware of is therapists that are doing this in their own offices with getting the prescriptions to partnering physicians who are just prescribing it to a pharmacy for them. And then there's a whole dialogue around that might be valuable to have about the pros and cons of that and how people are landing with doing that kind of practice and what that might look like later. And though we're not doing that, I just thought it'd be worth naming for the audience that there are people doing that, and that's a model that's out there as well, if there's questions about that. So I'll stop there.
So the next question, I'd like to focus a bit more on, I know we mentioned a little bit about PTSD and trauma work, but have you seen any types of conditions, cases, clients, anything that might be better addressed by ketamine versus the other types of work that you've done in the past, kind of the evolution of both the clinical practice model, but also perhaps if that is the case, or it might not be. I'm curious if there are kind of niche areas that you found best served by the CAP practices. And we'll move on to the research question next, being mindful of time. Signi, would you like to also chime in on that one?
Sure. Like from a therapist point of view, so having been doing this for 7 years now, my immediate response to that was like, I've never seen a diagnostic category that can't be helped by this. And I almost don't want to say that because it sounds like everybody can, but there definitely are things that I think have stood out. I agree with you on depression. One of the things that I sort of feel the impulse to highlight a little bit right now is trauma, because there is a narrative out there about it not being good for trauma. And that has just not been my experience. I think that to the extent that there's been some maybe complicated outcomes reported, it may have to do with more with the set or setting, the container, and the preparation integration context in which that's happening. I don't know. I work with a lot of trauma, and it's been one of the most successful modalities I've ever used for trauma, because people are able to tolerate distress differently. They're not as triggered by things that they are normally triggered by. They're able to sit with things they're triggered normally triggered by without going into overwhelm. So it creates almost a kind of a buffer stance where you can see your trauma. It's not, you're very clear what's happening, but your nervous system is actually regulating a little bit differently in that context. And so that has almost become to me like one of the main diagnostic categories that I think I tend to work with. And so I just wanted to highlight that, just because I know that there are differences of opinion out there, but as someone who just does this all the time, that's just what I'm seeing. And so I just thought I should name that. I have actually developed a sort of niche practice in OCD, people with diagnosed OCD. And that's been really interesting because there are no real protocols out there. What I was doing was basic ERP, exposure response and prevention protocols, sort of like accommodating those and doing those while, on the altered state. And so that's been really interesting because that's been really successful and not something that I necessarily would have anticipated going in. So I just thought I would put that out there. I know there's been some studies, but that's just an area we don't hear about as much and is really disabling illness. So
we did receive a number of questions that are excellent. Manda, if you'd like to bring up the ones that you've seen.
Yes, I'm going to try and bunch them together so we can kind of categorize and be more efficient with these questions. A couple of questions are from psychologists. One is in Berkeley and the other one is in Canada. And one is starting CAP therapy. The other one is going to get their training. They are kind of asking questions about how to think about starting clinical practice, attachment issues, complex trauma. They just want kind of like a roadmap of how to get started and how to make it a little bit more granular. And then once we answer this question, I'll ask another specific question from the other psychologist. Is there a roadmap?
I can speak to that if that's helpful. I would say no, and yes, and there's a need for that. And it's also understandable why there isn't. One of the complications of training to do, say, CAP specifically nowadays, but this would apply to any medicine, is that there's not a lot of like hands-on nuts and bolts how-tos that are taught. It's the expectation is that you take your existing skills as a therapist, which may be excellent, and you get comfortable with the idea of someone being altered, and then you just sort of do that, and I may be exaggerating a little bit, but there's not a lot of how-tos. And I have found that what's happening is therapists are finding their ways in all different kinds of ways over there, because there's not around, everyone who's been doing it. I mean, we developed the training that we developed specifically sort of partly to meet that need, because people were coming in saying, what do I do when I'm actually in the room? Like, yeah, I know how to do therapy, but this is different. This is not the same thing. You don't interact with people the same way. I actually feel strongly that it is a different skill set. You are building on your skills as a therapist, and you always will. You're not starting from scratch, but there are some different skills, and there are how-tos and how not tos that make it easier. And there's really not a standard out there that tells you what that is. What I would say to those people is, I'm not sure where they have been in their training, but I would say look for a training program that gives you a lot of demo videos or role plays, or allows you to sit with each other or with volunteer clients under supervision with a experienced therapist who's like helping you model, or so you get actually practice doing this under supervision, so that or it's certainly at least that it's demonstrated for you. We've built a lot of that into what we do for this very reason, because that is exactly where people get stuck. And so I feel like people come out of training programs often with a lot of theoretical knowledge and a lot of information, but they still don't feel super confident to step into a skill set. That's a very different thing. So my belief is that trainings need to focus more on people having experience on the medicine and on developing that skill set. We've tried to do that in our program, and I think others are starting to try to do that as well. And hopefully in the future, there will be more of that, but there hasn't been that much up to now. So with those individual people asking the question, I would get a CAP training that gives you those things that I mentioned. So you've seen it done, you've seen it modeled, and you've actually had a chance to practice it with someone kind of supervising you and giving you feedback. And that's not necessarily an easy ask right now, because a lot of training programs are limited by how much experientials they can give people or how much of medicine they can have people sit for. But I think that this is an evolving thing. I think it is getting better, and a lot of the programs are trying to rise to meet that need. And I forgot to say something, which is that after you've done your first few clients, it will feel different. Because I see trainees make this shift all the time. When the first time you're in there, you're like, oh, I'm the lead therapist. Like I'm supposed to, because you're not just a sitter, you are doing therapy. And what do you do? Right? By the time you've done your second, third one, fourth one, you're going to feel like, okay, I got the rhythm of this, and I kind of see who I am as a person in this work, like what my skill set looks like and who I am in this. And we see people kind of make that transition all the time. So it is sort of like getting started and finding your confidence level and your sort of sense of what kind of therapist you are in this space. But you do need a training program that helps you find that and develop that for yourself so that you feel at ease. Yeah, I probably could say a lot about that. I mean, I understand that is like one of the hurdles. So I would encourage whoever's asking that question to lean into a little bit, that it's awkward and different at first. This isn't something that our traditional training taught us how to do. And then just trust, if you know that you're safe and you know that you're holding all of the space in a good way, just trust that you'll get your footing. And we've seen a ton of people go through that journey, and it always feels awkward at first. So.
Great, thank you. Okay, one of the questions is, this person is finding that half of their clients go inward during CAP sessions and do not speak, even at lower doses, 0.5 milligrams per kilogram. Are you prompting them to speak, or are you reserving therapy for non-medicine sessions? How are you finding it's going for you?
We're prompting them, at least in our model. Yeah. I mean, this is all discussed ahead of time. That's, they're agreeing to this, and, because otherwise we're essentially being a sitter, which is an invaluable service, but it's not taking advantage of the psychotherapeutic potential. So we are prompting. And my strong feeling based on experience is that most therapists are hesitant to do that at first because it feels like you're interrupting something that's happening. And almost every client will say it actually deepens it. For them to be able to speak it actually deepens it into their memory or anchors it in more and enriches it. So don't be afraid to prompt people periodically. Like if there's been a long period of silence, and the key is to do that gently, obviously, and in an invitational way. And if they don't take the invitation, then that's fine. But you'd be surprised. So most of the time they will speak. And obviously there's a dose piece here, but I heard the questioner say that the doses were already not too high. Mm-hmm. So
great. Thank you. People want to know if anybody has experienced treating bipolar disorder. And also, I think, Meidad, you may have mentioned about this. I think you mentioned the end-of-life therapy, perhaps. So if we could touch on these two for people that have experience with these.
So I can attest that there's actually a recent publication that just came in July of 22 about ketamine and bipolar disorder. I will share a link to the article with Ingrid, but there is evidence that ketamine can be used safely. Obviously not folks that are actively manic, but patients that are in their depressive state, they can be safely used with ketamine. And with respect to end of life, coming from background of emergency medicine, and often I see patients that are coming in and no one talked to them about what they're facing. Like the expectation is that we will create a miracle, but in reality, we as a physician in those settings knows that they're not leaving this hospital anytime soon. And so starting that discussion and offering that service have been very powerful to people on so many levels, from the depression itself or the anxiety with end of life to the experiential element, not just the pharmaceutical, but the experiential element, and the combining. And through my household practice and starting to work with doing home visits and seeing people and working with death doula, which is something that I was not aware of until 4 years ago. I knew about birth doula, but not about death doula, and learning to work with them and then working with very experienced therapists that has been in the end of life has been very powerful experience, and there's a lot of room. And it's really sad that in where I live, for example, there's 4 facilities and they don't offer ketamine, and it's a hospice, and hospice and palliative care, and they don't offer that. And so I think there's missing a lot. There's a lot of room for that.
Great, thank you. Is there also are you finding that clients are interested in using ketamine for psychospiritual growth as opposed to symptom reduction or treatment of mood disorders?
Yes, for sure. And I think that this is very individual, but it's, now that we talked a little bit about experiential medicine, we're coming to the point of how am I, as a physician who carry the liability, obviously, through the entire operation, how do I feel about those who are coming for treatment-resistant depression and those who said, oh, I read Michael Pollan, How to Change My Mind, and I want to do ketamine. And so do I want to take those patients, right? Because now they're not coming in under a diagnosis, or they're not coming in under a specific track. But in essence, I think that we in our practice have learned to combine it a little bit, because all of us, myself included, could use therapy in one way or another. And us expanding our mind is essentially differentiating and growing and trying to better ourselves in so many other psychological issues that have been just trapping us to where we are. And so you can integrate those people, but you have to channel them into working with, a licensed therapist, someone who is experienced. And in our practice, we are, at least at this point, we're not one of those clinics who are nilly-willy, like, come on in and have experience. But we are kind of channeling them to, if you want to do the work, then you do it right, you do it correctly.
Great, thank you. There are questions on insurance. If any of the clinics take insurance for any portion of the therapy as well as malpractice, like how does that work?
We are a fee for service. We do issue super bill, so people can file with their insurance. Most insurance at this point might cover some Spravato, but less than, there are some that are coming around and prescribing, but we personally don't work with insurance for many other reasons. I'll let Bob comment on that, or John.
Yeah, hopefully the insurance landscape will change over time. There's advocacy happening on that, but it's hard to know. And I just wanted to just say really quickly, there are therapists who are able to bill for preparation and integration under insurance, which is part of the total cost for the client.
I really wanted to thank everybody for their time, their insight, their wisdom. And this was a wonderful evening. And it sounds like there are some more questions to go and insights to be had. So thank you so much, everybody. We look forward to more. I do want to have Signi just conclude with any last thoughts.
Thank you. Yeah, thank you guys for coming. We're wanting to do more of these, and we really want to make them really useful. And we are really excited to be just getting a lot more energy around offerings and growing it. So we feel like we have a lot more things in the pipeline that we want to start putting out there. So thank you for showing up for this, and we're looking forward to doing more of it, and we'll let everybody go on time.